So now regarding the management part of this, we have the basically the general strategies for all autoimmune hemolytic anemias, and these would include mostly and because most of the cases, since most of them would be secondary, also for both warm cold we have secondary causes, so we need to treat the underlying cause. If there's infection, that would be treatable, and if there is a malignancy, even in treating the malignancy would in fact even help in treating the autoimmune hemolytic anemia associated with it. So, and if it's drug induced, then just stopping the relevant medication would be enough. So so not only treating the underlying cause, but then also blood transfusion, since blood transfusion is an important component of, since the hemoglobin may drop very rapidly due to hemolysis. So we need to have fully compatible blood. But the only reference that they've made in these guidelines regarding the full compatibility testing is that it can take 4 to 6 hours for in order to avoid that sort of a delay in treatment. ABO, RH, and KEL matched RBCs can be issued in cases of so ABO, RH, and KEL matched RBCs. They can be issued in cases of life-threatening anemia. So and this life-threatening anemia, they've mentioned that if it's like less than about 6 hemoglobin, 6.5 sort of HB gram per deciliter. So then the patient should be in emergency, can be transfused even with this. And this would depend also not only upon the amount amount of the level of hemoglobin, but this would also depend also upon the clinical condition of the patient and also the comorbidity. So even taking this into account, even as low as 9 may sometimes be treated with transfusion. And when they are, and in case of cold hemagglutinin disease or mixed autoimmune and PCH, in these patients, the care needs to be taken to use a blood warmer for transfusion, or you can ensure that the transfusion takes place in a warm environment. That is, patient is also comfortable. The blood bag is like pre-warmed, and the transfusion is done through a blood warmer, and then the tubings and all, like the environment of the patient is also warmed considerably to make them comfortable. Then regarding the warm autoimmune hemolytic anemias, the specific measures would be that they have mentioned all these 4 options, that is immunoglobulins, plasma exchange, methylprednisolone, and emergency splenectomy can be done. But regarding guidelines, they recommend that mostly it is the IVIG and the plasma exchange that is done for severe and life-threatening anemia. This methylprednisolone and splenic emergency splenectomy and splenic embolism, they are only for special cases. So we mostly have this IVIG, that is intravenous immunoglobulin, at a dose of 0.4 to 0.5 gram per kg per day for 5 days. And they suggest that 40% of the patients, they respond to this dose. So 40% respond to this 0.4 to 0.5 gram per kg per day for 5 days. So and here the hemoglobin would also be not only does the patient respond like the response is not only quick, but it is also maintained for about more than equal to 3 weeks. So even like for about 3 weeks, even the response may be still be there. And then the response are predicted by the low pre-treatment hemoglobin and IVIG, and it is accepted that even the hemoglobin is less than 6, but of course, as I've mentioned, that patients with comorbidities, then even at higher hemoglobins, then they may be sort of issued these IVIGs. They may be prescribed IVIG treatment, and or they may be, it is maybe a temporizing measure prior to splenectomy. So even before splenectomy, even just to raise the hemoglobin to a acceptable level for splenectomy to occur, they may give these IVIGs, since the response is rapid and it is also sustained for about more than equal to 3 weeks. Then with plasma exchange also, the response is rapid, but it is only temporary. So here the response lasts for about more than equal to 3 weeks. So But here the response is very temporary, and it may be used only in patients with severe hemolysis while attempting to control them with other therapies such as immunosuppression. So just like IVIGs may be sometimes just temporary measures prior to splenectomy, they may be used because alone none of these actually works alone. IVIGs can in acute cases help to raise the hemoglobin level and maintain it for a few weeks, and after it is actually that time where the patient may be actually prepared for splenectomy. And plasma exchange may also be like a sort of a temporary measure where the patient other and therapies are being instituted, and methyl immunosuppression with methylprednisolone may be started, or certain maintenance therapies may be planned for that patient, but just as a temporary measure when plasma exchange may be started in severe hemolysis. And then methylprednisolone, they have mentioned that the high doses of intravenous methylprednisolone, because of the side effects, they have the use is usually limited, and they have role in fulminant cases, but the risk of serious infection. So they are actually also used in emergency cases when there is fulminant hemolysis, and just to uh, uh, bring the hemoglobin up to a certain level, but long-term use, these guidelines do not actually recommend that. And emergency splenectomy may be done in patients with the severe transfusion-dependent hemolysis, or where when who have not responded to immunosuppression. So if and some of the other measures they fail, and also the patient is now transfusion dependent, also then they may require urgent hemolysis. And in this case also, if the patient is not vaccinated 2 weeks prior, then they should be vaccinated about 2 weeks after post splenectomy. So as the functional antibody responses are improved by that time, so then the splenectomy may be done. In critically ill patients with warm autoimmune hemolytic anemia deemed unfit for splenectomy, then even those patients may be given, they have been documented success with partial splenic embolization. Then primary cold hemagglutinin disease, here also the recommended options are that of steroids and plasma exchange. And so there we had mostly IVIG and plasma exchange. Here we have steroids and plasma exchange. The steroids, they can be they have the guidance have maintained that they have a limited therapeutic only when there are can be they're not used in high doses, and they can not be sustained for long period of time. But trial of prednisolone, that is 1 milligram. So here the dose is 1 milligram per kg per day, and this may be considered as a rescue therapy. And then plasma exchange, even for cold hemagglutinin disease also, the response will be also just transient, and like in warm autoimmune hemolytic anemia, it is just done for stabilizing the patient while other alternative therapies are being planned or instituted. And the agglutination can occur within there. So another problem with plasma exchange in cases of cold hemagglutinin disease is that sometimes the plasma exchange apparatus, the cell separator and its tubing, this can also cause there can be agglutination even within that, especially if the agglutinin is active at 37 degrees centigrade, and the room and extracorporeal circuit may need a high temperature setting. So plasma exchange or daily or alternative exchanges of 1 to 1.5 times the plasma volume with albumin has also been recommended in certain cases. So sometimes plasma may be exchanged with albumin, and in these cases, daily or alternate days cases, they have responded with in case of cold agglutinin disease. But care needs to be taken so that the extracorporeal circuits, they have a high temperature setting, because otherwise if in the presence of cold, the agglutination would also occur within the tubing and the cell separator itself. So now the non-emergent managements, that is those maintenance therapies that would be in place. These include the general measures and the specific measures. Now the general measures are actually 4 steps regarding venous thromboembolism prophylaxis, and then institution of folic acid therapy, and also for because of steroids, since steroids will be the mainstay of the specific management. So then gastric protection and osteoporosis prevention, these needs to be taken to avoid the Now patients, mostly all patients basically are given folic acid supplementation, and this is because most of the because there is this reticulocytosis and stress on the marrow, so most of the cases would develop in long term megaloblastic anemia secondary to folate deficiency in patients with chronic hemolysis. So the folate is advised for all patients. Regarding thromboprophylaxis and this gastric protection and osteoporosis, we have to identify certain patients who need to be given this therapy, this prophylaxis. So folate is for all, but this venous thromboprophylaxis is mostly in patients who have like severe anemia, and they have defined this as anemia less than 85 gram per liter, and mostly in patients who have acute exacerbation of hemolysis. So when there is acute exacerbation of hemolysis, and in patients are admitted inpatient, and they will be of course not ambulatory. So in non-ambulatory patients and with acute hemolysis, when the hemoglobin drops to less than 85 gram per liter, so thromboprophylaxis should be considered. And even in ambulatory patients also, if there is severe exacerbation with the hemoglobin less than 85 gram per deciliter, so even in those can be considered. And this is in the case of low molecular weight heparin that is advised to these patients. So thromboprophylaxis for inpatient with acute exacerbations, and for ambulatory patients during severe exacerbations with hemoglobin less than 85 gram per liter, thromboprophylaxis should be instituted. And also for gastric protection, this is also for those patients who are going to receive this steroid therapy, and this is mostly done for patients who have um, this is mostly done for patients who are elderly with more than equal to 60 years of age, and who have a prior history of peptic ulcer disease. So in elderly who have a prior gastric disease like peptic ulcer disease specifically, then in those cases, and those who have concomitant thrombocytopenia or concomitant or they are concurrently using these NSAIDs and antiplatelet agents, or then these should be so those cases with thrombocytopenia and those who have concomitant thrombocytopenia and those who are concurrently using these NSAIDs and gastric agents that can cause pelvic peptic ulcer disease, so they are also then receive this proton pump inhibitors as the routine prophylaxis. So those patients who are elderly or who have a prior history of peptic ulcer disease, or those who have concomitant thrombocytopenia and are concurrently using NSAIDs and antiplatelet or anticoagulant agents, they will be of course at risk of bleeding and gastric. They need gastric protection. So and then for those cases and so for those cases that have this that are going to receive long-term corticosteroids, then for those patients also, amongst them, or basically all patients should receive this oral calcium and vitamin D supplements while taking the steroids. And this calcium, they have mentioned that it should be about 1200 to 1500 milligram calcium, and vitamin D should be 800 to 1000 units of vitamin D. So around about the thousands, we have like 800 to 1000 for vitamin D, and 1200 to 1500 milligrams for calcium. So these supplements are for all. Just like folic acid was to be given to all, even calcium and vitamin D supplements can be given to all these patients who are going to receive long-term glucocorticoid therapy, and to reduce the bone loss in these patients. But then especially in patients who are like in men aged more than 55 years and post-menopausal women who are going to be receiving corticosteroids, then they should receive bisphosphonate as if the therapy is anticipated to be more than equal to 3 months at a dose of prednisolone more than equal to 7.5 milligram per day. So if the high dose prednisolone is going to be used, um, or if the duration of therapy is going to be prolonged, then in those cases also we need to give them bisphosphonates specifically. So basically routinely calcium and vitamin D, and specifically bisphosphonates in postmenopausal women and men aged more than 50 years of age. And also we need to document their bone mineral density. Now this needs to be documented before the bisphosphonates are instituted as a part of the therapy. And so their baseline sort of a measure of their bone mineral density also needs to be done. Now the specific management strategies, they would include, they are actually, this is a chart that they have mentioned, and this autoimmune hemolytic anemia is since it is a chronic condition, so the goal of the therapy is to control the disease with minimal side effects, and patients with mild compensated hemolysis may not require active therapy. And while death with uncontrolled hemolysis can still occur, with the relative contribution of infection in patients on immunosuppression is significant. So basically the therapy is monitored so that side effects are reduced. And then this is the algorithm that we'll be going through regarding warm autoimmune hemolytic anemia and paroxysmal cold hemoglobinuria. That what the doses of basically this is going to be a sort of a repetition also in the case that prednisolone 1 milligram per kg per day in adults and 1 to 2 milligram per kg per day for pediatric population. And then folic acid, calcium, and vitamin D, and then this PPI, low molecular weight. This general management is basically the same that we have gone through earlier. So this management of prevention of these general preventive measures that are taken, and then specifically these steroids. The first line would then be steroids, prednisolone, and the second line in the case of warm autoimmune hemolytic anemia is the rituximab, and the third line are these immunosuppressive agents, that is the um, uh, cyclosporin, azathioprine, and danazol. So all these um, uh, immunosuppressive agents, and mycophenolate mofetil is also amongst those immunosuppressive agents that are used. So first line we have the steroids, and then second line this rituximab, this monoclonal antibody. Then we'll probably, I think, go into the text as well. So the text then mentions that for the first line for primary warm would of course be corticosteroids, and approximately 80% of patients, they respond to corticosteroids at a dose equivalent to a prednisolone 60 to 100 milligram per day. And we had mentioned earlier that the dose is 1 milligram per kg per day in case of adults and 1 to 2 milligram per kg per day in case of children pediatric population. And if the dose, the total dose, it is equivalent to 60 to 100 approximately. So most patients do, about 80% do respond to this dose. And approximately 2/3 then achieve complete remission also on the steroids. So the initial response may take several weeks, but the response would of course be like not so, it would take some time. And so it may take about 3 weeks even for the response, but like absence of response by day 21 should be considered as steroid failure. So basically, since we had mentioned that IVIG is given at about, and intravenous immunoglobulins, they are instituted as emergency management with the 0.4 to 0.5 gram per kg per day for 5 days, and then they maintain the hemoglobin for more than equal to 3 weeks. So during these 3 weeks, we may have started these steroids as well, and then after 3 weeks, when we take them off, so when after 3 weeks, when the effect of IV immunoglobulins sort of tapers off, the steroids should have taken their time. And then after the steroids have been instituted, then they are again monitored for 3 weeks, that is 21 days. And if beyond this time, even they do not show any response, then they are considered as steroid failure. So as a general timeline, we consider that if the patient presents with acute exacerbations, we will give them IVIG for warm autoimmune hemolytic anemias. And those warm autoimmune hemolytic anemias would then take about, they are instituted for 5-day period, 0.4 to 0.5 gram per kg per day. and they take around about they can maintain the hemoglobin for 3 weeks, during which time the steroids may also be instituted, and it may take like several weeks for the initial response, but then if like after if by day 21 if their response is not still there, maybe if they are started like 1 week from here and then also 1 week afterwards this week, so all these 3 weeks of steroid also, if no response is there, so then they would be considered as a steroid failure. And in responding patients, however, an incremental tapering is done. So patients that do respond, however, we start with a higher dose of steroid, and then we can also taper it down, bring it down. For example, once hemoglobin of about more than 100 gram per deciliter is maintained, or after a maximum of 3 weeks. So either if the hemoglobin is maintained more than 100 gram per liter, or after a maximum of 3 weeks, then we can reduce this dose of 60 to 100 milligram per day to reduce it to 20 to 30 milligram over this 4 to 6 weeks. So uh, if the response is there after day 21, we can continue with this response for another 3 weeks, and then start to taper it down over the next 3 weeks or the 4 to 6 weeks, and then bring it down even to 5 milligram every month. So they may even be started on pulse therapy with the just a weekly steroids for each month. So this is how we go with steroid. That is, we administer it in a high dose along with probably IVIG just to overcome the glute exacerbation. And then by 3 weeks, their effect should have taken should have come should be present. If it is absent by about 21 days, then they should be considered a steroid failure. However, if the response is there, then we can sort of continue for 3 more weeks at the same dose, and then after during the next 4 to 6 weeks, we can taper it down, bringing it down from 60 to 100 milligram per day to 20 to 30 milligram, and then generally even then start with pulse doses of 5 milligram every month. So in a series of 33 primary autoimmune hemolytic anemia cases, the relapse was more common if steroids were tapered to less than 10 milligram in less than 2 months. So all this time, it actually takes a lot of time. So there are like 3 weeks here, and 3 weeks here. So mostly like about more than 2 months should be given this time. So if the steroids are tapered in less than 2 months, and if they're stopped in less than 6 months, so the two time frames that we need to take into account is that is they should be not be tapered before 2 months, and they should not be stopped before 6 months. So these are also important things that need to be considered. So approximate and otherwise relapse would be more common. So as a general, when we start with steroids, we should continue with the sort of a dose for about 2 months. That is, we had mentioned earlier that for 3 weeks we watch for the response to occur, and if the response occurred, we continue at the same dose for about more 3 weeks, and then we gradually start to taper it down. So we don't sort of taper it down before the 2 months before 2 months, and then we then maintain it at this at the dose of 20 to 30 milligram. We reduce it 20 to 30 milligram over 4 to 6 weeks, and then 5 milligram every month, and this should be continued for another like 2-3 months, and so the total time duration should not be less than 6 months. So it should not be stopped at less than 6 months of duration. And then approximately 20% of patients remain in remission after steroids are discontinued, although a further 40% can maintain an acceptable hemoglobin on maintenance prednisolone, that is less than 15 to 20 milligram. Due to the long-term side effect of steroids, second-line therapy should be considered. So, so once that this remission has been achieved as a primary, like we give them these these steroids, and then the hemoglobin is maintained for about the hemoglobin is within an acceptable range even on maintenance. then just going on giving them long-term steroid would make give actually place them at more risk for side effects. So second line therapy can generally be considered here. And regarding dexamethasone, the data they have mentioned is that is very limited, and they do not suggest that dexamethasone is superior to prednisolone. So the preferred agent would be, in case of corticosteroids, mostly prednisolone. And prednisolone diazole 1 milligram per kg per day is the first line, and then second line therapy should be considered if firstly if there is no response to this high dose after 3 weeks, that is 21 days, or if there is relapse during or after steroid reduction. And even in cases where the hemoglobin is maintained on a maintenance dose of prednisolone, then we can consider second line therapy if you do not want to continue with the long term use of steroids. So the best studied, and so this regarding second line treatment, the best studied and most efficacious is the rituximab and splenectomy. In approximately 70% of cases, they respond to splenectomy, but even higher response rates are reported with rituximab. So basically, for second line, this rituximab and splenectomy, they go by equal, hand in hand. But the case with rituximab is that, of course, there will be like no surgery needed, and with splenectomy, and so there's you can avoid the risk of surgery. And with splenectomy, although there will be the surgical risk and this post-op splenectomy complications can be there, but the responses are also, the 70% do respond to splenectomy as well. So it can be considered mostly considering the financial status, or perhaps other conditions can be so following splenectomy, refractory or relapsing patients often require immunosuppression, and the rate of serious infection appears higher post splenectomy. So given the significance of infection and chronic course of autoimmune, most patients will benefit from an effective, well-tolerated steroid-sparing agent prior to consideration of splenectomy. So even before splenectomy, it is they are given this choice of rituximab. So as a second line, the main choice of rituximab, if there is like no response by day 21, then they are given this rituximab. And if there is no response, then this splenectomy is considered. And this rituximab is also, this response rates of 100% have been reported. And following rituximab for primary warm autoimmune hemolytic anemia, in series including primary and secondary warm autoimmune hemolytic anemia, 79% responded with this complete remission in 42% cases. And prior splenectomy does not adversely affect outcome, although better outcome is associated with the shorter duration of autoimmune hemolytic anemia. In the only prospective randomized study, first-line rituximab and prednisolone was compared to prednisolone monotherapy. So at 12 months, uh, the cure rate were 75% versus 36% respectively. So median time to response is approximate. So with rituximab also, as we stated with the steroids, steroids or non-steroids also, the response can would occur usually after about like 21 days. It can take some weeks, several weeks, and so even 21 days can occur. In the case of rituximab also, the response can would take around about 3 to 6 weeks. So it is more than, of course, that for steroids. Steroids generally respond within about 3 weeks, and if beyond the 21 days, we would start considering them as steroid failure. But the response for this it comes even later, so that is 3 to 6 weeks, and the range, however, is between 2 to 16 weeks even. So it can occur even beyond 6 weeks also. So 2 to 16 weeks can even pass by for considerable response to occur. And then the long-term remission rate is unknown, but relapse occurs in 14 to 25% cases after a median of 15 to 21 months. And then also the rituximab is largely well tolerated, although severe neutropenia and transient infusion-related reactions or infections have been reported. So even though with rituximab there is neutropenia and infections and transient infusion, so with rituximab this care must be taken because there will be a transient infusion related reactions. So some pre-meds have to be given, and also following rituximab there is this severe neutropenia that can occur, and so infections with the infections have been reported, especially reactivation of hepatitis B virus is a potentially fatal complication, and the pre-administration screening with serology for HBV surface antigen, and so the serology for HBV surface antigen and HBV core antibody is recommended. So uh, either this because prior to this the screening is done for HBV surface antigen and HBV core antibody. So HBC and HBS antigen, they are both the HBS antigen and the HBV core antibody is recommended. And progressive multifocal leukoencephalopathy is a rare complication. This can also occur with this um, multifocal leukoencephalopathy can also occur with rituximab. So the standard regimen is the 375 milligram per meter square weekly for 4 consecutive weeks. But even low dose rituximab can achieve profound B cell suppression when used for autoimmune disorders. So even the low dose of 100 milligram weekly for 4 weeks. So 375 milligram per meter square weekly for 4 consecutive weeks, or then we can even use 100 milligram weekly for 4 weeks with prednisolone. First or second line produces comparable response rates. Rituximab, however, so the only thing about rituximab, although we had mentioned that it is very beneficial, that the response is there with second line is better than with splenectomy, and splenectomy has its own complications. But rituximab also has these complications of transient infusion related reactions, because of which pre-meds need to be given whenever it is administered, and also this neutropenia and the infections and reactivation of hepatitis B virus. So before this, we need to have the screening for HBs antigen and HBV core antibody. And then the dose also may need to be adjusted in certain patients. For example, in some way we give the 375. The standard is to give 375 milligram per meter square weekly for 4 consecutive weeks, but it can also be 100 low dose 100 milligram weekly for 4 weeks with prednisolone as a combination therapy. So, however, rituximab was used at an early disease stage than studies of standard dose therapy, and variable definitions of response and short follow-up further limit the comparison. Now, primary form autoimmune hemolytic anemia, in the second line treatment, the recommendation is of course the rituximab. These are the BCH guidelines. And the third line treatment would then be they are listed alphabetically so as to show no preference. So basically this is just an alphabetical arrangement, but they have shown no preference. Either of these can be used, either cyclosporine, azathioprine, and danazol, or mycophenolate, mofetil, or splenectomy. Either of these 5 can be used. So for azathioprine, the approximately 60% of the autoimmune hemolytic anemia patients, they respond to azathioprine. So I just like mention here again that we may need to reconnect again after this after the meeting ends because of the 40-minute interval. So then I will continue with this third line treatment and splenectomy, and also the treatment for mixed autoimmune hemolytic anemia and the chronic hemagglutinin disease. Uh, mm, we'll see if we can manage this childhood autoimmune and paroxysmal cold hemoglobinuria also today, but up till now I think if we just do the warm and the cold and the mixed type, the general management of this, then we may consider this childhood autoimmune and the PCH and autoimmune hemolytic anemia in pregnancy. I think we'll try and cover it, but let's see how much we can do for today. So regarding this regarding this the third this third line therapy. Azathioprine is used in the dose is 100 to 200 milligram per day, and 2 to 20 they respond to azathioprine 100 to 200 milligram per day, along with the 2 to 2.5 milligram per day if it is used with prednisolone. So if it is used alone, it is 100 to 200 milligram per day, or if it is used with prednisolone, then the dose is 200 2 to 2.5 milligram per day. Or so the dose is actually variable. As I mentioned, different studies have different doses. And however, the number achieving response, steroid independence, and the duration of response is also unclear. And then this is another, as with the other therapies, the side effects we mentioned with rituximab to be infusion reactions and those reactivation and infections and neutropenia. So with the azathioprine also, the thiopurine methyl transferase, the TPMT, thiopurine methyl transferase deficiency. In patients who have this deficiency, this prevents the azathioprine metabolism and should be excluded prior to commencing therapy, because in these cases, since it prevents the metabolism of azathioprine, so these patients they have to be excluded prior to commencing therapy. And I think one of the reference there was also that these patients they probably need more higher dose of azathioprine, because they cannot metabolize this azathioprine. So I will confirm that. In about I'll actually confirm this later on. And, as for cyclosporin, also the dose is 5 milligram per kg per day, and with danazol, the dose they have mentioned is 200 milligram 3 to 4 times a day, added to steroids. And this can be also along with the, this is not used alone, but it's usually added to other medications. And with mycophenolate, that is the dose is 500 milligram twice daily. So danazol would be 200 milligram 3 to 4 times daily, and mycophenolate is 500 milligram twice daily, titrated up to 1 gram twice daily. It can be even given up to 1 gram twice daily. And the response typically takes about 3 to 4 months with the danazol, with mycophenolate. Sorry, and the splenectomy also, the patients with splenectomy, they have um, the response occurs within the first few months of surgery, but slower responses up to 5 to 6 months have also been reported. So approximately a third of patients, they may relapse after splenectomy. And response is of course higher in primary autoimmune hemolytic anemia than in secondary, because in secondary there would actually be an underlying cause that needs to be basically treated to treat the autoimmune hemolytic anemia. So with primary, we can go for if all causes of secondary have been ruled out, we then should go for a splenectomy. And also splenectomy is generally reserved for patients who do not respond, who are transfusion dependent, and they are not responding to second line other second line or other immunosuppressive therapies. Then radioisotope scanning has also been used in some cases. And the infections, although early studies suggested relatively high splenic uptake would predict a good response to a splenectomy, this was not supported by subsequent studies. So and also the infections, also the vaccination and the revaccination schedule should be based on the guidelines that have been developed, and prophylactic antibodies should be started post-operatively, and a course of antibiotics for emergency use should be provided at discharge. And the thrombosis occur also. So these are risks with